Welcome to this third in the series of videos from the Practice Protection Committee. I'm Pat Bailey, Medical Director in the DC office of the American College of Surgeons. I'm pleased to have with me today Dr. Mark Savarese from the University of Utah, where he is an Associate Clinical Professor. Mark and I have actually known each other for 24 years, having served together in the United States Air Force at Keesler Air Force Base. And after we left and went our separate ways, Mark chose to go into private practice. And so the topic of today's video is going to be, how does one make the decision to go into private practice? And then in Mark's circumstance, how does one decide that it's the right time to leave private practice and go into employment? So that will be our topic today. And thank you very much, Mark, for joining us.
Thanks, Pat. It's good to see you again.
So, Mark, when you left the Air Force, what went into your decision to pursue private practice?
Well, you took off for academics, and I was never really an academic. I wasn't interested in publishing or research. And, back in 1990 and 2000, there was a pretty distinct dichotomy between employed academia and private practice surgery, especially in smaller communities. So my ambition was to become a community surgeon and get out into the community and get practicing as quick as I could. Pretty much all of the jobs that I looked at across the country as I was separating from the Air Force were some form of private practice. It was, everything was, there were similarities and differences, but they all had the basic tenet that the practice was owned by the physicians who made some or all of the financial decisions for that practice, and was not owned by a corporation or a hospital per se. And all of the physicians had some sort of affiliation with their local hospitals. So I was clinically, that's what I wanted to do. And so there was really never any question for me that it was going to be some sort of a private practice thing. I didn't have a particular interest in owning a business, and I certainly had no experience in doing any of that.
When you went into private practice, what issues did you find most difficult to overcome, and did you find that those challenges got more numerous and acute over time?
They definitely got more numerous, and I started actually paying attention to them. So like most people starting out in private practice without a business background, physicians go in and usually you have a guarantee for a year or two, and then some sort of a buy-in process, and you become a partner in the practice, which was my situation. And you sort of learn things as you go. You don't know a lot of these things when you sign the first contract and start your employed year. And it gives you sort of a buffer to figure out some of the business aspects of the practice that may or may not agree with you, with the opportunity to get out after that first year or two if it's not something that you like. For me, I got in and I started learning that stuff. I got my paycheck every 2 weeks, and started figuring out about the practice. And for instance, the first month I was there, I discovered that we didn't have health insurance. I had just assumed that being a healthcare delivery company, our small business had employee health insurance when I signed the contract, and I got there and found out from the office manager that no, we actually all had to get individual health insurance. And so then I started learning about employee benefits and how that worked, and self-employment taxes and how that worked, and the basic accounting of a practice and how that worked. And I kind of learned that stuff on the fly. And as you know, especially in the, from 2004-ish or so on, regulations started piling up. There were government regulations, there were board requirements, there were all these different things that started, you had to learn these things as you went along. There was nobody there to explain meaningful use to you. But if you wanted to get that initial bonus and not end up with the penalty in the early 20-teens, you had to figure out what meaningful use was and how you went about getting an electronic medical record and implementing it. There was no playbook for any of that stuff. It was all sort of things you had to figure out as you went. I learned a bit about accounting. I still didn't understand accounting all the way through my entire time in private practice. We got income statements and balance sheets routinely from the office manager, and it sort of made sense to me, but really didn't. So I never really learned that. We had annual meetings with our insurance brokers to talk about not just the employee health insurance and things, but also our own insurance contracts that we were signing as providers. I had to learn about that stuff along the way. Every year, something got more complicated. The entire process just became more and more complex because there were new regulations from insurance companies, from certifying agencies such as state licensing, from the DEA, from CMS, from everybody else that we had to keep up with.
You were there in that private practice situation for a little over 12 years. Were there one or two specific issues that caused you to begin to consider seriously making a change to an employed status? And did you consider any other employment settings other than the university?
So first of all, my wife and I really liked living in a small town. Honestly, if we could have made the practice of medicine a little bit more conducive long-term in a small town, we might have stuck with it a lot longer. But in my mid-40s was a good time to start thinking that, well, if I'm going to make a change, I should probably make a change. And there was a carrot and there was a stick. The allure of going back to a university and teaching was there. But the things that pushed me were a couple things. Implementing an electronic medical record was a big deal. We had a 2-surgeon or 3-surgeon practice and a couple of people who worked for us. We had 2 full-time office employees and a couple of part-time clinical medical assistants. And all of a sudden, our full-time employees' time was completely taken up, and we had to enlist more help. And between the amount of time that I was putting into it, because my senior partner really didn't want to do it, and the time that our office manager was putting into it, we actually had to add additional staff to the office to make the EMR and meaningful use work. So that was onerous. It was a big deal. But that wasn't the main thing. The main thing actually had to do more with the practice in a small community. Our hospital struggled, like a lot of independent small hospitals. We were a 20, 25 bed little hospital in a little town that was sort of seeing the evolution of corporate medicine. And that's where it really hurt, because bigger hospitals in cities a little distance away were able to get new technology in, and they developed nuclear medicine sentinel node technology well ahead of anything that we could get. And that affected how we took care of breast cancer patients. And they developed advanced laparoscopic things well ahead of us because they were able to do that stuff and could start doing more advanced laparoscopic colon surgery and things like that. And so our elective practice was suffering, and our hospital, as the practice was suffering, was getting more money in and became less and less possible for them to invest in these new potential programs that we thought we could develop. We managed to get some breast stuff back. We developed a sentinel node. Our radiologist developed the ability to do more image-guided biopsy, but it was hard to do that in a small setting. And so every year we were falling a little bit further behind in the ability to provide state-of-the-art care, or at least the perception among the patients about state-of-the-art care. And so the elective patients were going an hour and a half to the big city to get that stuff taken care of, but they'd still come back to our emergency room at night with complications. And so the urgent stuff remained busy. So we were taking a lot of call and making less and less money doing it. That was the biggest thing about private practice. And I think that is something that's borne out in an awful lot of small towns around the country, with surgeons who'd been in private practice that struggled with it, that had to look for it. The reimbursement was going down and the amount of work wasn't going down. It was just being replaced with more busy work or less desirable work.
So you make the decision to, go into an employed status. Did you look at any other options other than with a university?
I really didn't, because the university came to me with this opportunity. Through my work in the college, I had actually stayed in touch with some of my mentors and some of the people who continued to work here at the University of Utah, and I sort of let it slip that if something came up, I'd consider it. And so that's how that happened. I didn't really look around at other opportunities. Now, that said, my partner who was left behind after I left is a much better businessman than I am. And he looked at opportunities for how to keep the practice going by arranging semi-employment with some of the hospitals around there. And so after I've gone, he's managed to arrange, some contracts with the 3 critical access hospitals that the practice now covers, and maintain a quasi-private practice that's somewhat, supported financially by hospitals. But for me, it was a complete change. I went from eat what you kill, complete private practice where we made all the decisions, all the hiring and firing, and we're responsible for all of our management of our practice, to employed by a state-funded university for 3/4 and the VA for 1/4 of my salary. So I work 3/4 for the state of Utah and 1/4 for the federal government now. And it's completely the opposite.
So when you left your private practice, what sort of process, procedures, issues did you encounter in actually closing down your component of that practice?
Yeah, so that was a bit of a lesson for all 3 of us. There were 3 in the practice at that time, and at the same time that I left, the senior partner retired, leaving just the junior partner in charge of the practice and recruiting. So there were a couple things. There was the clinical, what to do with all the patients that we had. I helped my junior partner essentially recruit our replacement coming right out of a residency program, a nice guy who's worked out great, and the 2 of them continue to run the practice. But we essentially closed down that practice and they restarted as an entirely new entity. And so there were all the business decisions that had to go into that. The things that turned out to be real difficulties were 2 things. One was sort of the accounting for tax and reimbursement purposes of the practice. And we were able to divide the accounts receivable pretty evenly, but the accountant who'd been doing our stuff, working primarily for our senior partner and also doing my senior partner's private taxes, had made the accounting such that the vast majority of equity in the practice belonged to the senior partner, and the junior partners getting out actually owed the senior partner money for that. And we had never really worked that out and didn't understand the accounting principles of how that could happen. And so 9 months after finishing the practice, and when they sat down to do the annual taxes for the year, that was a very unpleasant surprise. Finding out that went on, and it left a lot of bad feelings among the 3 of us as the practice broke up. The other thing that was an unpleasant thing was we knew that we had a liability program through a private insurance company that didn't include our tail. And so I knew there could be a tail expense. Joining a big institution, the big institution is completely self-employed for its malpractice. And so it's not like there was an ability to transfer that tail to the new institution. So I had the big bill for the malpractice tail that I had to pay immediately upon finishing. And then finally, there were just some tax consequences of getting out of the practice that affected my personal taxes for the next year that I had to figure out as I got out. So it was all financial things that kind of did it. The arranging patient care stuff and the departure from things was pretty easy. I let patients know 90 days ahead that we were planning on this happening. We made sure that the transition was smooth otherwise. But dissolving the practice financially required some help from definitely an accountant. And in retrospect, it would have been nice to actually have just brought in an independent accountant to go back through that stuff instead of the guy who'd been doing my partner's taxes for the entire time.
So Mark, you've made this decision to leave, and you're in negotiations with the University of Utah. What sort of contractual considerations became really important to you? And specifically, did you consider having them pay that malpractice tail for you?
Since being here, I've actually worked with some of my graduating residents on employment contract language, and it's a confusing topic. We're not very good at it. When I negotiated my contract with the university, it was very simple. The division chief who had been the division chief back when I was a resident, kept things very simple. It was basically, you're going to work for us, you're going to do this much stuff, we're going to pay you. If there's any problems, we'll work it out. If there's a termination, this is how it happens. There is a non-compete clause in there that was both distance and time, that was not negotiable. And then the employer, the university, took care of all kinds of things like benefits. And it was just like, yeah, this is a standard benefits package. There's not really much negotiating with these things. And so it was very standardized, as you get from very big institutions. And I found that going on in the future as well. When I'm talking to residents who are joining Intermountain Healthcare here in Salt Lake City, there's no wiggle room in those contracts at all. Intermountain says, this is our standard contract, you sign it. Whereas one of my residents leaving and going into a much smaller practice had a ton of negotiation that he had to figure out. So one of the things I was interested in is, could I get this tail covered? And it was, I brought it up, but it was a non-starter, and it just had to do with the logistics of the way that their insurance worked. There was no way that their insurance was going to pick up my prior liability. So all it would be was essentially them making an additional financial contribution to cover that, which I didn't get. It would have been nice if I did. So I think going into the contract, everybody looks at what's the salary, what are the basic requirements. But of course, you end up overlooking the most important parts of the contract if that's the case. You don't look at what are the termination clauses, what are the hardship clauses, what are the clauses around disagreements, which are really the important parts of the contract. And you can talk to a contract lawyer about that stuff. The ideal thing, I think, is to talk to a healthcare contract lawyer in your state about those things, because they would have an idea of what's customary, what might be missing from a healthcare contract. An employment lawyer who doesn't know a whole lot about healthcare doesn't understand the malpractice issues, doesn't understand the non-compete clause issues very well. And those are actually very important things later on that are easily overlooked. And I'll admit that I didn't look very closely at those things. I was aware of them, but I'm like, well, I'll stay in this job. It's going to work fine. There's no reason to have to worry too much about that stuff, and I wouldn't argue about it.
Mark, you've been 12 years in private practice, a little over, and now then about 8 years there in employed status with the university. What do you find are the key differences and the similarities between those two practice environments?
Well, first of all, they're more similar than you might think. When you read the ACS communities, you get the impression that there's a vast difference between being in private practice and being your own boss and being employed by somebody else. But a lot of the reality for me is that practice is practice. You still have to be good at being a doctor. And if you're not a good doctor, word gets around and you don't do very well in your practice, no matter if you're employed or in a private practice setting. Your referring physicians are still very important to you. You have to have a good relationship with the primary care doctors who send you patients. That's just as important now as it was then. You have to have a good relationship with your patients. You can't be a jerk just because you work for a big institution. Patients will find out you're a jerk and won't come see you. There's the notion that you are now a cog in a machine and you don't get to make any of your own decisions. But the reality is, in private practice, you're still a cog in the machine. A lot of your decisions are based on what's required of you by your hospital, your state, the board, Medicare, your insurance companies. And it's the same now. There are just layers of people between those things, and so you don't see them. The biggest differences have been sort of the different onerous requirements. They are definitely less for me now than they were then. I spend much less of my time worrying about all of the ancillary administrative things, even though I have a little bit of administrative position. About 10% of my work is administrative, but that's been voluntary. But outside of that, the clinical practice stuff, you don't worry much. In fact, most of my 35 partners in my department at the university have no idea of what the CMS requirements are for meaningful use for any of the incentive programs such as MIPS now. You can ask them, they might have a vague idea of what MIPS is, but they don't do any of that reporting. It all gets done for them. You're told by somebody in administration that there's some new policy in your electronic medical record requires you to do such and such to meet these requirements, and you just do them. The VA does the same thing. There are requirements for things. There's still somebody who looks out to make sure you're completing your medical records appropriately, but there was somebody like that when we were in private practice that could make your life miserable. They just worked for the hospital. So the similarities, I think, actually outweigh the differences quite a bit. And I've gone from one extreme to the other. And I think that the people who are in the middle, who are working for a multi-specialty group or a integrated healthcare system and have, some sort of a hybrid RVU-based practice and things like that, the lines are very blurred now between private practice and employed. Everybody is in some sort of hybrid position.
So over the last 6 months, we've all been dealing with the pandemic and the impact that that's had on practices and frankly, our entire way of life. How has that impacted your practice there at the university and the VA?
Just like everybody else, we shut down everything elective this spring. We went from normal on a Friday to a phone call on Sunday that said, yeah, Monday we're not doing anything. Don't come in. Your surgery is canceled. We're calling everybody and telling them that they're not having surgery Monday. And we stayed shut down for a few months. So of course, revenues tanked while we were gearing up for all of the COVID response and putting together the tents for testing and all those things. All of our elective practices basically stopped. And then we started trickling back. We started back very cautiously with being able to do practice, and then we could do things that were semi-emergent, and then we could do things that were outpatient and wouldn't tax the system as much and things. So we've done what most places have done to respond to COVID. The financial impact on the institution has been sort of absorbed by the size of the institution. First of all, we've had some reserves, like most big institutions. We have some reserve capacity, unlike a small private practice or a small community hospital that runs with, only a few days of cash on hand. We were in a position where we could absorb some of that stuff and look at how we were going to manage it. So it wasn't a big surprise when our administration and our department chair came to us and said, everybody's going to take a salary cut and a cut in some benefits for a few months to a year, and depending on how things go, we might get it back. And when we had the faculty meeting, not a single one of the 35 surgeons spoke up in protest. Everybody was completely fine with a 12% pay reduction through the summer and elimination of 7% of our contribution to our retirement accounts for the rest of the year. We thought, that's not that bad, we're lucky. And senior administration let us know that they were all taking cuts as well, even though they were working. So that's been the biggest impact. Fortunately, like most of us, just like the institution, I've got a bit of reserve. It hasn't hurt to have that happen. And I've watched my RVU production take a big nosedive and then slowly start climbing back up. So I'm not feeling too bad about that.
So when we first started talking about your entering private practice, you said that you, like most surgeons, didn't have a lot of business acumen. And then subsequently, I know that several years ago, you made a decision to pursue an advanced degree in business. How has having your MBA helped you, and how has it helped your employer in terms of a value-added equation?
Going back and doing an MBA program in my 50s was a challenge. As you know, you keep going back to school for various things, and I think you've got another final exam coming up. I got interested because I applied for the health policy and advocacy scholarship that the college offers. The college and a few other professional organizations offer a scholarship to go to Brandeis University for a week in the summer to essentially get what's a 1 week introduction to MBA, which I thought was really interesting. And there were topics on accounting and finance, and there were topics on leadership and management style and things like that I found really interesting. The other reason for doing that is in a large organization like we've got, there are a lot of administrators. And I've noticed that they tend to speak a different language, which is very dismissive of the physicians sometimes. They think of us as just sort of producers of revenue, don't really understand things. And in order to get into the room with them, you have to speak their language, and it's Excel spreadsheets and PowerPoint presentations and finances and things like that they talk about. So I wanted to understand that more. I convinced my department chair that it was a good investment. He actually helped pay for the MBA program for me with the idea that I would come back and use it to some benefit. And so my payback for that is that I'm involved with program development, helping our institution try to align with some of the smaller hospitals around the region, in the state and in the surrounding states, to provide some services or help those hospitals expand services, or help our department get involved in services at some of the other places. So I've really come full circle from where I started out in private practice in a small hospital, in that now I'm talking to the general surgeons who are in those positions that I was in 12 or 15 years ago, in a small hospital, trying to figure out how to keep my breast program alive, or how to get back some colon surgery or things like that.
Mark, this has been always great to see you. It's been interesting for me to learn a little bit more about, your career and the way it progressed, and the factors that went into your decision making. And I know that our fellows will find this very useful and helpful as well. We'd like to ask that you continue to tune in for these continuing video series produced by the Practice Protection Committee. We wish you good health and good day.